received her Master's of Public Health and Bachelor's of Science from the University of Florida. Yeah, go Gators. But she began her career in public health and health education in 1997 as a diabetes educator, so a different kind of a chronic disease, working with chronic disease. Went on to work in the area of reproductive health and immunization research. In 2004, she became an on-site contractor for the CDC, providing communication, consultation, and project management, first in the CDC Office of the Director, and then at the National Center of Health Marketing. Please join me in providing the warmest welcome possible for our friend, Jill Roark.
Hello, everybody. Can you hear me? Is my mic working? It is. That's fantastic. All right, so I'm going to run through my objectives really quickly because they're required. So we're going to talk about why HPV vaccination is important. And can we turn down these lights a little bit? I mean, I know y'all want to look at me, right? But I didn't put on any makeup this morning, so just look at my slides instead. All right, so we're going to talk about, hey, why is HPV vaccine important? We're going to talk about how we can get healthcare providers to use compelling information to help parents make the decision to vaccinate their kids. It's still really bright. And how you can find resources relevant to immunization. All right, so while you read my disclosure, I'm going to redecorate. I like to walk around. I don't want to trip on the chairs. All righty, let's go. So we're going to do a top 10 list today. Everybody loves a good top 10 list, don't they? So I'm going to go through the top 10 facts about HPV. So number one, HPV, and I'm going to go through these in depth, but I'm going to just give you a little preview of them now. 10, it's a common infection, the most common. It causes cancer. Preventing cancer, believe it or not, better than treating it. We have an anti-cancer vaccine. How terrific is that? Hey, guess what? That vaccine is going to save lives, lots of lives. It's a safe and incredibly effective vaccine, and I mean incredibly, like probably the best vaccine we've ever had. More young people need HPV vaccine to help protect them from the cancers caused by HPV. We need clinicians giving strong recommendations for HPV vaccination. We need our clinicians to use the office systems to help support vaccination. And number one, we have resources available to help you in all of this. So let's go to our first fact. HPV infection is common. How common is it? It's incredibly common. It's the most common of all of the sexually transmitted infections. And that's about the last time you're going to hear me talk about it in the context of being a sexually transmitted infection. Lots and lots of types of HPV, not just the types that we talk about in the context of this vaccine, but HPV is everywhere. I mean, like literally everywhere. It's like all over your body. So there's sexually transmitted types and then types that aren't. The common warts in our hands and feet come from HPV infection, believe it or not. The ones we're concerned about today are those that cause issues in the mucosal, or we used to call it genital tract, but really the throat has nothing to do with our genitals at all. So the mucosal areas that can become infected with these types of HPV. So two main types. We have high-risk HPV, which causes the cancers. It can be in the cervix, anogenital region, oropharyngeal. So the oropharynx is the back of the throat, base of the tongue, and base of the tonsils. Precursors to cancer, so cervical dysplasia, for instance. Also low-grade cervical disease, so usually not requiring additional screening and treatment. And then we have the low-risk types, so 6 and 11. These are the kinds that cause things like genital warts. Or laryngeal papillomas, so those are warts that grow in the throat. When this happens in a child, it's juvenile onset, they can get what's called juvenile onset recurrent respiratory papillomatosis. These poor little babies end up with so many warts in their throat that they have to have several, sometimes hundreds of operations through their lifetime just so that they can breathe. It's a really sort of terrible thing to happen. And low-grade cervical disease can actually be caused by 6 and 11. It doesn't progress to cancer, but still occurs. All right, so more facts about HPV infection. If you're sexually active, which I'm presuming almost every single person in this room is, almost every person, you're gonna have HPV at some point in your life. But the good news is that 90% of HPV infections clear on their own, they're transient. We have about 79 million Americans that are currently infected with HPV. That's a lot of people. We have about 14 million new infections that occur every single year. Most of those are occurring in late teens and early 20s. I just said that. Most people never know that they're going to be infected. So how does someone know that they have HPV? Well, either visually, they can see that they have genital warts and someone told them that genital warts are caused by HPV, or this is a woman and she has an abnormal pap, and when she has her abnormal pap, she's told this is caused by HPV. Otherwise, nobody knows that they've had an HPV infection. Don't know that they have an infection that can be transmitted to someone else and possibly cause cancer. Okay, so we know HPV causes cancer. Let's talk about how much cancer it causes. So there's about 27,000 cases of cancer every single year caused by HPV. Doesn't seem like a ton, 27,000. That's one person diagnosed every 20 minutes, every single day, every single week, all year long. So it really is a lot when you think about it in the context of that. If you want to look at it in a slightly different picture, this is what it looks like for men and women. Breakdown, you can see when I talked about juvenile onset recurrent respiratory papillomatosis, 820 cases of that a year, 820 cases of babies having warts in their throat. So out of all of this, you can look at it divided by sex, which shows you the picture that most of the cancers in women are cervical cancer. Most of the cancers in men are oropharyngeal cancers. These are caused by HPV. Now, what's interesting about this is we've got somewhere around 11,000 women on average every year that are diagnosed with cervical cancer. But these numbers have been increasing, and it concerns us. By the year 2020, we expect that the number of oropharyngeal cancers in men is going to eclipse the number of cervical cancers in women, and not because the number of cervical cancers in women is going to go down, but we're seeing such huge increases in the number of HPV-caused oropharyngeal cancers in men. We can break it down and look at the picture a little bit differently. Hispanic women are affected by HPV more than any other racial ethnic group. Black women are more likely to die from an HPV-related cervical cancer than any other group. Lots of reasons for those things happening. So we know that there's some disparities when it comes to HPV and how it affects different groups. But one of the most important things we have is knowing that we can prevent HPV, because preventing cancer is better than treating it. If you don't know what it's like to have a cervix, I'm sure the men in the room don't know what that's like. If someone has an HPV-related precancer, cervical cancer, many different things they have to go through, colposcopy that's shining a very bright light on the cervix, and then treating it with acetic acid to see which parts of the cervix are growing too quickly, and that tells us the precancerous condition is there. One might have to have something called a cone biopsy or cold knife cone, where they cut out part of the cervix. Not a pleasant experience at all. When we talk about just women being affected by cervical cancer related to HPV, we have 4,000 deaths every year and nearly 11,000 new cases. And this is with a fantastic screening program in our country. We have an excellent cervical cancer screening program. 300,000 cases of high-grade cervical dysplasia, so not even talking about cancer, but 300,000 cases that are going to have to be screened, biopsied, and probably treated. 1 million cases of genital warts, 1.4 million cases of low-grade cervical dysplasia. That's 1.4 million women who are going to be told that they have an abnormal pap, which, by the way, is not the best news you've gotten all day. Costs our country $7 billion every single year. Most of this can be prevented with HPV vaccination. And that's really exciting. It's great. We have a vaccine against cancer. I promise you that if we had a vaccine against prostate cancer or breast cancer, we would not be able to have enough vaccine for everybody that'd be lined up to get it. So we have a little issue, though, because we don't like to talk about stuff down there. go back to talking about the vaccines for a second. So most folks know this, there's 2 vaccines, they do have some differences. Probably the most important thing to know on this slide actually is the contraindications. So there are a couple of contraindications for HPV vaccine. These are anaphylaxis level reactions to yeast for the quadrivalent vaccine and to latex for the bivalent vaccine. So it is important to know if a patient has a yeast or latex allergy, depending on which vaccine is stocked in the clinic. Hopefully by age 11, somebody knows if they've had a yeast or a latex allergy. And like I said, it has to be anaphylaxis level for it to be a contraindication. All right, so I'm just gonna quickly go over the routine recommendation because I think most of you in this room, I'm sort of preaching to the choir here, know about the recommendation, but routine recommendation for all girls and boys 11 and 12 years old. Also, if someone wasn't vaccinated and finished the series by the time they were 12, they should get it at age 13 or later. If that person is a male, then we routinely recommend that they receive the vaccine to age 21. If they're a male who is immunocompromised, is HIV positive, or is asplenic, doesn't have a spleen, we want to vaccinate them up to age 26. Also, men who identify as having sex with other men, we also vaccinate them up to age 26. Girls, up to age 26, no matter what. Can be started at age 9. This is important. A lot of people say, well, if the routine recommendation is 11 and 12, why do I care about age 9? Well, I live in the state of Georgia, and we recently had a physician call into a webinar we did, and he said, I have two patients in my practice who are 12 years old that are both pregnant. Should I be recommending HPV vaccine before 11 and 12? Yes. If you have any idea at all that you have patients that are already sexually active, whether it's consensual or not, yeah, they should be getting HPV vaccine before that. We know that HPV vaccine has the potential to save lives. This is really important. I mean, how often do we have the chance to say, I can protect you from cancer? Not very often. I mean, other than telling people to quit smoking, wear sunscreen, and eat their broccoli, we really don't have that, right? I mean, that's a lot of power in a little vaccine. So, today in the United States, we have 26 million girls that are under the age of 13 years old. If we did not have a vaccination program at all, nearly 170,000 of them would go on in their lifetime to develop cervical cancer. 50,000 of them would die from it. But we do have a vaccination program. The problem is we can't seem to get above more than a third of our girls getting the full series and being completely protected. So for each year that we are not improving our vaccination rates and getting to the Healthy People 2020 goal of vaccinating 80% of girls and boys by age 13, we're gonna see every single year 4,400 new cervical cancer cases and 1,400 deaths caused by cervical cancer. So just another way of looking at those numbers on an annual basis. This is what we can prevent. And every year that we're not, this is what happens. So these are the things that motivate us. We know how bad cervical cancer is. We want to prevent it. All the other HPV cancers, terrible. I know that we focus on cervical cancer a lot, and there's a lot of other cancers out there caused by HPV. They concern me the most, actually. Like I said, we have a terrific cervical cancer screening program in this country. There is no anal cancer screening program. I know there's some doctors using Pap tests off-label for anal cancer screening, but it's few and far between, and it's usually only with gay men. Now, interestingly, twice as many women every year get anal cancer caused by HPV as men that do. But the only people who are getting off-label Pap testing for anal cancer are gay men. Think about that for a minute. There's no cervical, there's no precancerous lesions of oropharyngeal cancer, so there's like no precancerous state, essentially. There's no way to screen for it. So we have all these other cancers that we don't have a terrific screening program for. There is no screening program. Those are really, really important to prevent infection of HPV for. And guess what? Not only do we have this fabulous vaccine, it's safe. And I wanted to put this up because I feel like this is such an important statement. When people say bad things about vaccines, it causes so much harm. causes harm in those 4,400 women every year that are gonna get cervical cancer if we don't improve our vaccination rates, the 1,400 women that are gonna die every year of cervical cancer, and that's just cervical cancer. That's only one piece of one of those two pies you were looking at. So HPV vaccine is safe. We've actually seen an incredible decline in the number of vaccine adverse events reports since 2006, which is really fantastic news. You can see the serious reports are the ones that are in dark gray. We've seen a decline in those as well. So less concern, less, there was a lot of hysteria at the beginning of the vaccine being out, so lots and lots of reports being out about concerns that HPV vaccine had caused a problem. I want to stay on this for just one more second. So when a parent brings their child in at 11 or 12 years old, and they say that they want Tdap vaccine and they say they want meninge, but they don't want HPV vaccine, and they say it's because they've heard that there's safety concerns. HPV vaccine is, besides MMR, our most studied vaccine. We have looked at HPV vaccine safety more than any other vaccine with the exception of MMR. We look really, really, really hard at the data. In fact, we have multiple data systems collecting information about HPV vaccine safety, and we've done all these additional studies looking for a problem. I mean, we're looking hard to see if there's a problem, and there haven't been. There's been no unusual patterns or clustering of any side effects that would suggest that they are caused by HPV vaccine. Its safety profile is the same as Tdap and meningococcal vaccines. Just as safe. It makes it no difference in terms of safety. But again, it's a vaccine to prevent an infection that happens down there. And that's scary, and we don't like to talk about that. This vaccine is very, very effective. One of the best vaccines that we have, without a doubt. It's amazing, actually. So how do we know that the vaccine works? Well, we look at it in three different ways. One, look at the early outcomes. So early outcomes are things that we can see within just a few years of the vaccine coming to market and being used. So things like declines in prevalence of HPV infection, declines in genital warts. The mid outcomes are things that we're not going to see for several years or perhaps a decade or two. So that's going to be things like your precancerous lesions of the cervix. Our late outcomes are going to be when we're seeing prevention of cervical cancer occurring or other HPV-associated cancers. And that might take us decades. But the good news is we already have data about these things. So in the first 4 years that HPV vaccine was out, so from 2007 to 2010, looking at data for the number of HPV infections, you can see that in 14 to 19-year-olds, which is the group that one, would have just been most likely vaccinated, because that's when it's recommended for, and two, they're the group that's most likely to have an HPV infection. We had a decline in by 56% in HPV infection. So in just 4 years, our infections were declining by half in the group we would most expect to see high infection rates. It's really exciting news. This is data from Australia. Again, early outcome data showing us reduction of genital warts. This proves the vaccine's working. You see the little dotted line going up and down is when their vaccine program started at the same time as the US. What's different about Australia is they got to 80% of their population, just girls, vaccinated super fast. And that makes them a little bit different because they created sort of a herd immunity idea. And the way that we can see this is not only can you see that turquoise line that takes the big dip all the way down to the bottom there in girls, but in Australia, before 2012, they didn't vaccinate boys. Yet, before 2012, that turquoise line for boys also takes a huge dip. So vaccinating girls, 80% of them vaccinated, reduced the incidence of genital warts in boys as well. So we know this vaccine is working. It's working really well. I don't have a slide for it, but we've actually seen data from Australia because they got to 80% so quickly. They're already starting to see declines in high-grade cervical lesions. So they're seeing that next step that we didn't expect to see for a decade or more. They're already seeing it, and we haven't even gotten to a decade yet. Very exciting. My next fact is that more young people need this vaccine, and they aren't getting it. They're getting Tdap and meninge, but they're not getting HPV vaccine. Let's talk about Texas for a second. So Texas, you're right there in the middle, just above, I'm sorry, you're just above the middle, right above the mean. And so this kind of puts in context where you are in terms of the whole country. Don't mind Rhode Island. They only have 20 teenagers. It's really easy to vaccinate nearly all of them. They're our outlier. Sweet Rhode Island. But in Texas, when I said that most kids are getting Tdap and meningococcal vaccine, we can actually look at the number of kids that are getting vaccinated with any vaccine. So they're getting to a healthcare encounter and they're getting a vaccine, but they're just not getting HPV vaccine. So in Texas, of the girls who've never received a single dose of HPV vaccine, 85% of them saw a healthcare provider in 2013, got a vaccination, but did not get HPV vaccine. If all of them had, your first dose HPV vaccine rate would be 93% instead of 56%. For boys, not quite as dramatic, but close. So for boys, 38% of them who had never been vaccinated saw a healthcare provider, received a vaccine, but didn't get HPV vaccine. You could be at 58% for boys instead of 34%. And really, I mean, it's not as dramatic, but frankly, nobody's real dramatic with boys yet because we've only been measuring for a couple of years. What's really important about this slide right here are actually the lines at the top that aren't HPV. So the red and blue lines, blue being Tdap, national coverage 2013 was 86% for Tdap, nearly 78% for meningococcal vaccine. And what this shows us is the issue isn't that preteens and teens don't get to the doctor, because guess what they do? They really do. Over 80% of kids by the age of 18 are still seeing their doctor annually. So they're getting to the doctor and they're getting vaccinated, they're just not getting HPV vaccine. So the issue is during the healthcare encounter. So this tells us here that in our current structure, with everything we have, healthcare exactly the way that it is today, no changes with ACA, no changes in state mandates, no changes in anything, kids get to the doctor and they get vaccinated, but they don't come out being vaccinated with HPV vaccine all the time. So stagnant HPV vaccination rates are going to leave another generation vulnerable to these cancers. Our vaccination rates for HPV are lagging behind, but high coverage rates are possible with our current structure. So what do we do? What do we change? Well, there was an excellent report. Now, I don't often think that reports written sort of at the national level are that fantastic and encourage you to, oh, I don't know, go online and read it or do what I did and actually request that a copy be sent to my home. But this was a particularly impressive and good read. And so basically, the National Cancer Institute puts together a panel of people that give a report to the president on some important cancer issue every couple of years. And so for 2012, 2013, this was about HPV-related cancers. And they convened people from all over the country in several different workshops, and they worked really hard to look at all of the data. What are we doing well? What are we not doing well? What can we do better? And what can we tell people that will help them improve our HPV vaccination rates? So there's 3 things that we can do. And these are 3 of the goals. There's actually 5 total goals within this report, but the last one is global, so we don't worry about it. But the first one, well, for us today, we do worry about it. The first is to reduce missed clinical opportunities. So when someone goes to the doc and they get vaccinated, but they don't get HPV vaccine, that's a missed opportunity for HPV vaccination. So we need to reduce those missed opportunities. 2, we need to increase the acceptance of HPV vaccine by parents and caregivers and even adolescents. There are some adolescents who, believe it or not, are influential enough in their families to tell their parents that they don't want a vaccine. And then we need to increase services to HPV vaccine. So what do we need to do? Well, it's right here in this picture. Let's just do this. We can all go home now. Not really, it's not that easy, is it? So 2 main ways to accelerate HPV vaccination uptake. One is directly from the provider to the parents, caregivers, and adolescents themselves. And the other is from this unknown entity that's not on the slide. We're going to call it sort of national public health, to both providers and to caregivers. So the first is a strong recommendation for HPV vaccine and the use of electronic office systems, and then communication strategies to both providers and the caregivers. So healthcare professionals should give a strong HPV vaccination recommendation. Well, what does that look like? What is a strong and an effective HPV vaccine recommendation? Well, it's certainly not saying that the vaccine is optional, yet that's what our data tells us. Our data shows us that healthcare providers very often present this vaccine as being optional. Our data also says that a lot of healthcare providers themselves feel like HPV vaccine is a new vaccine, and they have a lot of conflicting feelings about it. They present that to parents when they talk to them. They also feel that many of their patients are not at risk, and they share a parent's view that the child is not at risk. You know, so 13-year-olds in the office and the doc's thinking, surely this child is not going to be having sex anytime soon. Because none of us were thinking about anything related to that at that age. Everybody waits until they're 27 years old on the night they get married, right? Everybody. Certainly, any of you who have preteens, I promise you they're not thinking about sex. It's everybody else outside this room. She can wait. We hear this so often. Whether it's the provider or the parent, she can wait. She's going to wait. She doesn't need the vaccine now. But here's what's interesting. When we ask parents through the National Immunization Survey, for parents who said, I'm not vaccinating my daughter in the next year, and we say, why not? They tell us 5 main things. 3 of those are essentially the same and really should all be in one bar together, which is not sexually active, not needed or necessary, or lack of knowledge. Because it's really all the same thing. It's all lack of knowledge, right? Lack of knowledge about why this vaccine's important, why it should be given prior to onset of sexual activity, all that good stuff. We expect to see side effects, safety concerns, issues. We do expect parents to have those. We would be remiss if, as humans, we weren't concerned about doing things like giving ourselves shots or taking medications. It is normal to have concerns about those things. So we expect to see that out there. What concerns me, however, is that 13% of parents said, well, the doctor didn't recommend it. I'm not going to get the shot for my kid if the doctor doesn't say that my child needs it. So if we look a little bit deeper into the data, and this is slightly different data from Health Styles Survey, when parents who said that they would get their child vaccinated or had gotten their child vaccinated, they were asked, well, did the doc recommend it or not? For those parents who said that their kid would get it, 36% of them received a recommendation. 34% of them received a strong recommendation from the physician. So you got about 70% of parents there who the vaccine was recommended to them. Of parents who said, I am not getting this shot for my child, 21% of them said that the doc didn't talk about it and didn't offer a recommendation. But they talked about it but didn't offer a recommendation. More concerning, though, is the 45% of parents who said, I'm not getting my child this vaccine because the doctor didn't bring it up. So if you want to know why kids aren't getting vaccinated, it's occurring in that healthcare encounter, between the conversation between the parent and the provider. We know that most clinicians are waiting way, way too long to make a strong recommendation. The vaccine is routinely recommended for 11 and 12-year-olds. Now, there's all kinds of routine recommendations all over the childhood schedule, but we don't see physicians waiting to give parents strong recommendations for Hep B vaccine or for MMR. So why are they waiting to give a recommendation for a vaccine that could prevent their patient from having cancer? Because it's about down there. Well, I mean, clearly, right? Because they think that 16 to 18-year-olds are going to be more likely to be doing stuff down there, so they're going to give a really strong recommendation for it. Well, the irony of that is the 16 to 18-year-olds are already doing that stuff. They've most likely already been exposed to HPV, and at this point, the vaccine's not doing them a ton of good. It might be doing them a little bit of good. Hopefully, they don't have all 4 strains yet. But 11 and 12-year-olds, only 50% of them are getting a strong recommendation. Now, this is my aha slide. So, parents were asked, how much value do you place on these vaccines? So looking across the board, meninge, hepatitis, pertussis, flu, HPV, or lump all the adolescent vaccines together. You can see that parents on a 10-point scale value all of these vaccines pretty high. The spread is only 9.2 to 9.5. That's pretty high. Ask a provider, how much do you think parents value these vaccines? So for meninge, hepatitis, pertussis, providers say, oh, around 9.5 on a 10-point scale. However, if you ask a provider, how much value do you think a parent places on HPV vaccine? They completely miss the mark. Providers don't think that parents value a vaccine that could prevent their child from having cancer. But the parents do. You can see how this type of disparity is going to really cause problems in the conversation between a parent and a provider. If a provider thinks this parent doesn't want to vaccinate their child, it's going to set up a very different conversation. In fact, because of the backlash from childhood vaccine hesitancy, a lot of providers are already skittish about, oh my God, this is going to be the long conversation. This is the mom that always has 19 different questions and brings the stuff printed out from Facebook. I don't want to have this conversation. She's not going to want an HPV vaccine. It changes the conversation. So this first time mom has a question, the doctor shuts her down and says, well, we can wait. She doesn't need it yet. She hasn't even started puberty yet. And so they push the parents off. Now, I've actually gotten to hear some of these conversations, some really interesting research that was done where they tape clinician conversations with parents. And I was really surprised to hear docs so quickly push parents off because they're perceiving a hesitancy that's not there. What's interesting is when parents have lots of questions about childhood immunizations, typically they are on the way to delaying or refusing. That's not unusual. We know that from the research. When parents have questions about HPV vaccine, they're looking for reassurance. They're looking for their doctor to say, I know you read that on Facebook. I know it sounds really scary, but I promise you the data shows that this vaccine is very safe and it works very well. I know you want to protect your child from cancer, and I want that too, and that's why I'm giving your child HPV vaccine today when I give them meninge and Tdap. All right, so one of the objectives for reducing missed clinical opportunities is that providers should strongly encourage HPV vaccination of 11 and 12-year-olds. It's as simple as this: 3 vaccines at 11 or 12. You need them all at the same time. I like to call it 3-2-1 plus. Your child's going to need 3 shots of HPV vaccine, 2 shots of meningococcal, 1 shot of Tdap, plus influenza vaccine every year. An easy way to give the bundled recommendation: if you are a clinician, if you have an interaction with a clinician, encourage them to say, your child or your preteen needs 3 vaccines, and these vaccines are going to protect them against meningococcal meningitis, most of the cancers caused by HPV, as well as provide a booster for tetanus, diphtheria, and whooping cough. So take the HPV vaccine challenge. Whether you're someone who is a recommender, that'd be like the doc, a shot giver, the nurse, public health, a partner, any interaction with clinicians at all, this is what we want clinicians to be saying. So if you do anything, take this back. If you're a clinician, I encourage you, start your next vaccine conversation like this with parents of 11 and 12-year-olds, unless you think they need to start it sooner, which is fine. If you're someone who has an influence to work with clinicians, encourage them to give their vaccine recommendation this way. And the reason why is because when parents hear a bundled recommendation, they see all those vaccines on the same level playing field. But when a parent hears, well, next year, your child is going to need Tdap in order to start school, and meningococcal vaccine is, meningitis is really scary. Mom, have you thought about HPV vaccine? All of a sudden, mom thinks, oh, Tdap and meninge, really important, but my doc's not so sure about HPV vaccine. So I'm not so sure about HPV vaccine. So bundling those vaccine recommendations together tells mom all 3 of these vaccines, whether they're required for school or not, are equally important. HPV vaccine is not optional, because it's cancer prevention. So let's talk about sex. Yeah, let's not. Really. I used to be a reproductive health educator. I got no problem talking about sex all day long. However, the one place that should not be happening is in the context of HPV vaccination. In research with moms, they told us, don't talk to me about sexually transmitted infections. Don't talk to me about my child having sex one day. If you want me to make the decision to vaccinate my child, I need to hear about cancer prevention. They don't want to hear about HPV vaccine in the context of sexually transmitted infections or sex. If you have an 11-year-old, do you really want to be thinking about when they're going to be having sex? Not really, at all. So don't bring it up. It doesn't need to be part of the conversation. Now, I'm all for us having the conversation at some point, but not in the context of HPV vaccination. And this is really important. So most pediatricians especially, God love them, think that all of their patients are going to be celibate forever until they're ready to have babies. That is not exactly the truth. So one of the reasons HPV vaccine recommended 11 or 12, look at this by the way, is at what age they have vaginal penile intercourse. Now, we all know there's a lot of bases you go around before you get to home, right? So this is not the age at which we've touched somebody else's body parts with one of our body parts. This is the age at which we start having sex. So lots of other stuff is happening before here, but you can see that right about age 13, it zooms up very quickly. Get them vaccinated soon. For parents who say, oh, but she's young, he's young, my son plays with his N64 still, but yeah, so does my husband. We're still having sex. Come on. When do we put the bike helmet on? Most parents are comfortable talking about things like car safety, bicycle safety. When do we put the bicycle helmet on? When do we put our seatbelt on? Is it A, before we get on our bike? Is it B, while we're riding down the street with our hands off the handlebars putting on our helmet? Or is it C, after we've already had the bike accident? Why are we waiting to give HPV vaccine after they've already had sex? That makes no sense. So for the parent who says, well, she's not sexually active yet. Yeah, exactly. That's the point. HPV vaccine is best at 11 or 12, not just because they haven't been exposed yet, but also preteens have a very high immune response to HPV vaccine, higher than older teens and young women and older men. All right, so this was an ad that we placed in a nursing journal. Now, I know that everybody in here works in immunization, but surely you know other nurses that don't. And this is really important just as a message to all of us. We are not just immunization advocates in our work life, but it goes everywhere with us, right? Everybody knows I work for CDC. Right now they ask me about Ebola, but before that they all ask me about immunization. It happens to everybody. Somebody says to you, what do you know about this vaccine? What you say matters. HPV vaccine is important because it prevents cancer. All right, so we also want healthcare professionals using their office systems, electronic systems. So we improve what we measure. Electronic office systems are one of the ways that we can look at the data that we have about coverage rates. So if you are in a position to be providing AFIX visits, I think sometimes they get called COCASA because that's where the data comes from CDC, but provider feedback is an excellent way to help improve immunization rates. So is reminder recall, and guess what? It really does work. We've got a couple of different studies that have shown us, and this is in the community guide, that reminder recall works. It doesn't matter what vaccine it is. It works just as well for HPV vaccine as it does for TF and meninge. Even though the rates in general aren't as high, it works just as well. We have all kinds of programs here in the state of Texas that can be used. If you're not sure whether you're working with a clinic or within a clinic, what can be done to improve immunization services, there's a great piece from CDC that just asks questions. Are you willing to do these things? Do you have the capability? We have resources that can help you. So I love it when a national report gets written and they name CDC in one of the objectives. Now, no other agency got named, just CDC. So apparently we actually have to do this, which we are. So we've created a lot of really great resources, and this is one that I highly encourage for healthcare professionals, created just for them. You are the key to HPV cancer prevention. I know for a fact, because I got a lot of friends that are doctors that work at CDC, they really don't like to read a lot, bizarrely. I think they did all their reading in medical school and said, I'm done. So we made this really easy website that has 3 tabs. 1 page, 3 tabs, that's it. The first one is our overview tab. It's got some good stuff on it, including a tip sheet on how to talk about HPV vaccine. The second one has resources for the practice, so things like free continuing education. And then the last is handouts to give patients and parents. You can get from us a great presentation like the one I'm doing today to talk about the importance of HPV cancer prevention. You can get it from that website. We've got our free continuing education, our fact sheets, 3 different levels here. We use a plain language writing system at CDC. Everything's in plain language, but we know that parents require differing amounts of information. So we've got our most basic, which has all the vaccines on one sheet for adolescents, one that's a little bit more in depth. By the way, the ones that are less in depth are English on the front, Spanish on the back. And then our third one, which is for our highest information seeking parents, so those parents that are high SES, higher degrees, has some real emotional appeals. It has a story from a cervical cancer survivor in it. Oh yeah, I forgot that it did this fancy stuff. All right, we have our adolescent immunization schedule. I don't expect any parent to be able to read the one that CDC puts out, so we created this easy to read one for parents. We have all of these in Spanish as well. You can also send parents to our Vaccines for Preteens and Teens website, or if you're looking for things yourself, resources, all kinds of great resources on this website, including how to get our free materials. We have a great infographic. We're actually printing this right now. It's going to be in the CDC warehouse. A lot of people like this. We published it with the NIS teen report. We have posters. I'll let these sink in for a second. For boys too. We have some video PSAs, looking for a PSA to put on TV or in a doctor's office. You have these in broadcast. If you would like more information about our campaign, please don't hesitate to email us at preteenvaccines@cdc.gov. I can tell you how to get all this information. We also put out this really fantastic newsletter called Preteen Vax News. It goes out ad hoc, so we don't clutter your mailbox every week or anything, but usually once a month or once every couple of months. If you send an email to preteenvaccines@cdc.gov and say, put me on the list, we will add you to our mailing list. The next thing that comes out on the mailing list is going to be when all of our materials, our free materials, are in the CDC warehouse and you can order them. And if you would like to talk to me, if you have questions about HPV vaccination and how to improve coverage, you can email me at jroark@cdc.gov. We can stop HPV. We can stop it in its tracks, I promise you that. That's what I got, thanks. All right, questions. I know you got them. I'm not that good. Come to the microphones. Oh wait, microphone
Actually,
coming to you.
There it is. Yeah.
Is that working?
Yes.
Okay. My name's Audrey Munoz, and I'm with the local health department here in San Antonio. And I'm wondering, on your numbers, does that include, as far as kids who are having intercourse, does that include youngsters who are having intercourse against their will?
Yes, it does. So in fact, 6% of kids under the age of 13 have already had sexual intercourse. I'll let that sink in, 6%. Most of those, it's not consensual.
And there's a lot that are having it that aren't in those numbers. I can promise you,
Well, those are national numbers, so it's an aggregate of the whole country, and there are definitely pockets of the country where there's more going on than others.
Yeah, I mean, because a lot of it doesn't get reported.
Well, and those
So much.
that's based on report by the kids themselves. That's from the Youth Risk Behavior Surveillance Study, which actually, believe it or not, kids are incredibly adept at self-reporting, much more so than adults. Adults have a lot of bias when we self-report, and kids don't have that bias. It's amazing. They actually do a much better job than we do. More questions?
Hi, my name's Daisy Morales Campos. I have a question about the strong physician conversations. How are you defining that? Like, what does the physician actually have to say for it to be considered a strong conversation?
Sure. So a strong recommendation is saying your child needs HPV vaccine today. We recommend that that be done in the context of the bundled recommendation, so putting it together with Tdap meningococcal vaccines, which is why it's so easy to 11 or 12, because that's when those vaccines are recommended as well. A lot of parents are okay with that, and many parents respond to the bundled recommendation extremely well. However, there are parents who are still going to have questions, and those questions are not hesitation, delay, or refusal. They're a need for reassurance. And so the next answer is, mom says, well, why does my child need this? Your child needs this because it prevents cancer. And then then you can answer, and we've got all of this in our tip sheet. See, I'm not going to show you the tip sheet because I want you to actually go to the website and get it. But our tip sheet shows how to answer, how a clinician can answer each one of those questions very effectively. So whether it's a question about safety or my child's not going to have sex yet, the one that I always tell parents, my parents ask me this all the time, well, my child's waiting. I appreciate that. I think that's wonderful. But what if your daughter doesn't have sex until her wedding night, but the person that she marries already has? So the gift she's getting from her spouse on her wedding night might be HPV. Is that really what you want for your child? So lots of questions like that. So a strong recommendation is one that doesn't make HPV vaccine optional.
Hi. Oh, sorry.
I can't tell where you're coming from.
Oh, right here.
I'm
sorry.
Oh, there you go.
I just had a question. You said earlier that Australia hit 80% really quickly. What did they do differently?
So many of the countries that have gotten to 80% really quickly have in-school vaccination. Now, this is different than school mandate. This is where they receive their healthcare services in school. And so parents are used to that. The kids get all kinds of vaccines in school, and it's no big deal all the time. They sign a waiver, my child can receive healthcare services at school, the kids get it while they're in school. So that's one way it happens. Rwanda is another perfect example. Their first try at HPV vaccination was 96% vaccination rates. First try. They do it in 6 days. They take people to all of the schools on day 1 and day 2 and vaccinate every single girl in 1 grade. And then on days 3 and 4, they get all those girls that were absent. On days 5 and 6, they go out into the communities for the girls who were absent days 1 through 4. And they vaccinate 96% of the girls at age 12 within 6 days. So, small country, a lot of resources put towards that, but just different in terms of structure. One over here.
Hello, my name is Jovita. Usually our parents don't come back after the second dose of HPV. I guess it's better than not getting vaccinated at all. Does it work just as effective as getting the 3 doses? And how many times do you recommend, let's say if they come back 3 months later for that and we restart them, how many times do you recommend us doing that?
So you don't actually ever have to restart the HPV vaccine series. While there's minimum intervals, there's no maximum intervals. So if someone doesn't come back for 4 years and they only need 1 shot, just give them that 1 more shot. We're still collecting data around how effective 2 doses are. Not all countries use the same vaccination schedule. But what's different is about our vaccination schedule that we use is that there's 2 priming doses. So that first dose and then the second one that's 1 to 2 months or 6 weeks out is actually a second priming dose. In order for it to be a boost, it has to be 6 months out. So some of the countries that have data around 2 doses being very effective actually do their first 2 doses 6 months apart. So that is required. Now, the sort of beautiful thing that's happening is so many people are taking forever to come back and get vaccinated that we're actually seeing some really good effectiveness. But for now, while we still have a recommendation for 3 doses, we want kids to get all 3 doses. And that's where some of the systems things come in play, like reminder recall and things like that. And yes, it can be hard. We see a huge drop-off between 1 and 2. We see the exact same drop-off between 2 and 3. And it's different things that keep people from completing the series versus starting the series. It is easier to get kids vaccinated with all 3 doses the younger they are. So it's easier to get them finished if you start them early.
Hi, I was wondering how you would handle the adverse news and media from other countries on HPV. Just example, Colombia's mass hysteria recently.
Yes. So, and we've had similar things in the US. There was actually, in the Northeast, a cluster of girls who had, essentially it was a term mass hysteria, but they developed tics and things like that, and a handful of them had gotten HPV vaccine, and so a group sort of descended upon this area, an anti-vax group. So we've had to deal with a lot of this. There's not been really great data around those things. Japan is another example where they've had the, I think they call it systemic pain or generalized pain syndrome. Not excellent data. They haven't done really great look into the individual cases to say what was caused or not. Like VAERS is a passive reporting system. So once a cluster of something shows up in VAERS, then we go in and look really closely at the data for that. Vaccine safety data link, same thing. The unfortunate thing in some of these other countries is there hasn't been great data looking at the individual cases to say, this is or isn't caused by, the vaccine. Now we know it's not causing any serious side effects. But I would say that the thing you have to say is, we have really great data in the US. We've 67 million doses of HPV vaccine have been given out since 2006. In all of the years of safety studies that we've done on those 67 million doses, we have not seen any serious side effects caused by HPV vaccine. And there's all kinds of stuff in the media that we have to confront all the time. We get a lot of questions on the CDC website, and we just link people back to the information. And the other thing to do, too, is say, the risk of cervical cancer, the risk of other HPV cancers, the risk of anal cancer is a colostomy bag. The risk of oropharyngeal cancer is having to have radiation that keeps you from being able to swallow. So these unknowns around could it cause these things and the information coming from other countries is not very much. Another good example is fertility. That's one we hear from Australia all the time, women saying, well, I've heard that this can cause issues with fertility. We have no data to support that. There's no data to support that HPV vaccine can cause any issue with fertility. I mean, essentially it's like, oh, it's all about down there, so we worry about that. But what you can say is that we know that if HPV causes cancer of the cervix in a woman and she has to have a hysterectomy as her treatment, that keeps her from having a child. So that is causing a fertility problem. So arm them with facts. And then also, I feel like some of the powerful stories like we have of our cervical cancer survivor on the CDC website, she has an incredibly powerful story about why it's so important to vaccinate your kids.
Big round of applause. So not only do we get amazing information and data here, we got amazing science on how to communicate it, and based on your questions, what you heard here is driving you towards a desire for right action. So what I heard in terms of the actions you want to take, just based on the questions that you gave, you want to be able to take action to get kids vaccinated earlier. That's why Audrey asked her question. How do we persuade providers and parents to vaccinate earlier if we know that not all of those numbers that we're seeing there are voluntary sex? And so when we look at those numbers, what does that mean? You know, based on your questions, you want to know how you can intercede to improve the conversation between healthcare providers and parents. That's why you're asking about what is a strong recommendation. We know that you want to be able to take the action of raising our U.S. rates, of accelerating our rate towards 80%. That's why you're asking, what did they do in Australia? And how do I address these questions that are coming from other countries? We know that you want to take that action. We know that you want to take the action to have, to make sure that we are using the best evidence about the safety and the efficiency of this disease, and you want to make sure that we are providing the full coverage. Take the action of providing full coverage. How many times? And thank you for that, because we are more than 3 months before our final one, so it's good to know that we are not out of the game. So you are armed with all of the information and the motivation you need to accelerate us to that 80% and to cover as many children as we can now, and adolescents now, to prevent cancer. That is the myth. This is about our ability to use a vaccine to prevent cancer. Please join me in thanking Jill for providing us with those tools and books.
Thank you. Awesome.
Thanks. Terrific.